Hello, my name is Leda Coelewij, and I'm going to talk to you about my project using metabolomic and transcriptomic profiles to predict the formation of anti-drug antibodies in multiple sclerosis patients. In this project, we focus on the relapsing remitting form of the disease, and we look at patients who have been treated with interferon beta. We look at anti-drug antibodies, which form as a response to a therapeutic antigen and are associated with reduced clinical effectiveness. ADA testing isn't routinely performed, and instead patients are monitored for loss in treatment efficacy, which is usually in the form of an increase in disease activity. We propose that combining multi-omic signatures with patient features will establish a tool to predict patients who are likely to develop ADA. To do this, we look at patients at 3 different time points. This is before they start treatment, M0, 3 months on the treatment, M3, and 12 months on the treatment, M12. At M12, we determine if they have developed ADA. Then from this, we do retrospective analysis at both M0 and M3 to try and predict the formation of anti-drug antibodies. We then look at either metabolites or whole blood transcriptomics. The first part of these results focus on patients at month 0, that is, patients before they've even started the treatment. This volcano plot shows the results of the differential gene expression analysis, which reveals 669 upregulated genes and 28 downregulated genes, which pass an FDR of 5%. A heat map of the top 10 up and downregulated genes show that patients are clearly clustered based on their ADA status, and a further look at these 10 genes identified genes that have previously been associated with either neurodegenerative diseases, autoimmune disorders, or MS. Pathway enrichment analysis on these 669 upregulated genes revealed a few interesting pathways, including membrane trafficking at the top, a variety of signaling pathways in the middle, and metabolism of lipids at the bottom. These suggest strong signatures of immunogenicity at baseline, but interestingly, when we compare these signatures to progression in 1.2, this PCA demonstrates that ADA-pos patients in blue seem to cluster together very strongly with SPMS patients in red. Instead, ADA-neg patients in black seem to cluster completely on their own. This suggests that transcriptomic signatures of ADA at month 0, prior to starting treatment, overlap with signatures of progression. Furthermore, we also looked at machine learning models using metabolomics to predict ADA at month 0. The majority of the models, including support vector machine, logistic regression, and random forest, predicted ADA with an accuracy of around 80%, with the best one predicting at 84%, and an AUC of 0.8, with the best one having it at 0.87. This also identified various metabolites of interest. And so finally, in 1.4, we wanted to see how this might correlate together. So we looked at the correlation between gene counts of the genes that were involved in metabolism of lipid pathway identified previously and the lipid counts, lipid concentrations. And what we can see is that there are very strong positive and negative correlations between the two, showing that the gene counts may be involved in the metabolite concentrations as well, suggesting these signatures may overlap. The next part of my results look at the altered response to interferon beta in ADA-pos patients at month 3. In 2.1, I show the percent change in metabolite concentrations in response to interferon, where ADA-neg patients are in blue and ADA-pos patients are in red. What you can see is that in some cases, while ADA-neg patients have an increase in these metabolite concentrations, ADA-pos patients actually show to decrease. Meanwhile, some metabolites might show that both patients will decrease in the metabolite concentration, but to different severity depending on ADA status, suggesting an altered response to interferon beta. This is further confirmed while looking at the transcriptomics analysis. In 2.2, I show how the interferon genes which have previously been associated to interferon beta therapy are differentially expressed between ADA-pos and ADA-neg patients. In this first set of graphs, what you can see is the time course transcriptomics of these interferon genes associated with response to therapy. At first, what you can see is that at baseline, which is in red for both ADA-neg and ADA-pos patients, these interferon counts are quite low. At month 3, in a light blue here, you can see that for both ADA-neg and ADA-pos patients, these counts jump up. What I hope you can also see is that the extent to which ADA-neg patients jump up in these gene counts is far larger than what we can see for ADA-pos. Finally, in green, what you can see is that at month 12, in ADA-neg patients, these interferon counts are still high, whereas in ADA-pos patients, these counts go down to baseline, suggesting an altered response between the two groups. But furthermore, we want to see if we could develop some sort of threshold at month 3 to identify a strong interferon response in those who are ADA-neg and a weak interferon response in those who are ADA-pos. And in fact, in this last graph, what you will see is that when we look at a score or a threshold 2 standard deviations below the ADA-neg mean, what we can see is we have some sort of a threshold where only one ADA-pos patient comes close to reaching this, whereas only one ADA-neg patient seems to pass it. This further suggests that we can develop an interferon score and cluster patients by ADA status at month 3. What I hope I've shown you today is that we've identified early signatures of ADA using both metabolomic and transcriptomic analysis at month 0, that is, prior to even starting the treatment itself. We've also identified an altered response to interferon beta therapy in ADA-pos patients compared to ADA-neg patients, and this was seen using both metabolite concentrations and gene expression. In the future, we'd like to validate these in other cohorts or expand our analysis to other omics, such as proteomics. We'd also like to see how our signatures correlate to those that we see in progression. Thank you very much for all of your attention.